The Institute for the Study of Peak States presents the first International Psychoimmunology and Psychobiology Research Symposium. Using psychobiology to heal chronic symptoms of traumatic brain injury, presented by Dr. Mary Pellicer.
Okay, just checking if there's any other. Right, I think that's it for now. So I'm pretty certain Mary will be right to start her presentation now. So thank you very much, Kirsten.
Mm-hmm.
Okay, Mary. So Dr. Mary Pellicer is trained as a family practitioner and worked for a number of years in a migrant health clinic practicing conventional medicine. She left conventional practice after 5 years to explore more holistic ways of nurturing health. She originally met Grant in 2000 and worked with ISPS for 5 years in the early days. She even managed to get her name on one of his books as the co-author. Mary rejoined the Institute staff 3 years ago as the Medical Director of Applied Research, specifically to bring the traumatic brain injury process to a larger audience. Dr. Mary has been in patients over the years, the devastation and suffering what is caused by traumatic brain injury. She's very excited about the potential for this ISPS process to help with the often hidden disability of chronic TBI. Her presentation will focus on using psychobiology to heal chronic symptoms of TBI. So Mary, over to you.
Thank you, Shane. Awesome. I want to start with Micah. Micah was 59 when he came into contact with an ISPS therapist doing the TBI process. He was living in Hawaii with his wife and 18-month-old daughter. And other than the problems caused by his multiple head injuries that you can see there listed on the screen, he had no additional health problems. After his last TBI, about 10 years prior to this, his life had changed dramatically. And he basically couldn't function as he had been before. He was generally physically fit, but had a lack of energy, lots of headaches, pain down his neck, lots of cognitive symptoms. He was only able to work as a part-time caretaker because that's all he could manage. He had had hopes and dreams of setting up his own business, being a coach. But after the accident and his life changed so dramatically, that was just not possible for him. What he said was, after his last accident, it affected my cognitive abilities and my life was over as I knew it. He also said he didn't feel like a normal human being. And he described this feeling of a loss of self and a feeling of disorientation of self. Let's talk about the problem. What is traumatic brain injury, TBI? A TBI is basically a bump, a blow, some kind of jolt to the head that disrupts normal functioning of the brain. The main causes of TBI are falls, motor vehicle accidents, sport injuries can certainly do that, accidental, and in the case of boxing, on purpose, and assault. TBI is generally categorized into different levels of severity. Mild TBI, the vast majority of TBIs, fortunately, are mild. These are also known as concussions. Concussions are defined as having only a brief, if any, loss of consciousness. PTA, which stands for not Parent-Teacher Association, it's post-traumatic amnesia. So PTA of less than an hour. And key here is that generally there's no findings on brain imaging. Those are normal, the MRIs or the CT scans. Moderate TBI, when we go up to the next level, again, loss of consciousness now is from 1 to 24 hours. PTA, again, 1 to 24 hours. And this is the breaking point where now the medical professionals are seeing some abnormalities over either very mild or extraordinary on brain imaging. And then when we get up to severe TBI, which fortunately are the minority of traumatic brain injuries that occur, loss of consciousness, greater than 24 hours, sometimes even coma, where the person is not coming out and is not regaining consciousness. PTA is more than 24 hours and often very abnormal brain imaging results. Let's talk about the symptoms of TBI. TBI symptoms can be all over the map. When I first rejoined the Institute and started diving into this, and I just want to make clear here that I am not a neurologist, I'm a family doc. I'm not specializing in TBI, I haven't taken any special, so this is just my interest, and I'm learning as I go along some of these special things. There was no categorization I could find for symptoms, or there was categorization, but everyone did it different. So to keep my sanity, I basically looked at all the symptoms that were reported in TBIs across the map, all kinds of case reports as people were talking about this, and categorized them in these 5 areas. This is not all the symptoms there can be. Those are legion, can be just about anything, because our brain is doing so many different things in our body and our psyche. But these are just some examples. Physical symptoms, headaches, neck pain, absolutely huge. Many people with TBI have these, they become chronic. Dizziness, easily fatigued are also common. Sensory symptoms with the eyes, sensitivity to light, very frequent, blurred or even double vision, sensitivity to sound, a loss of taste or smell. Some people will develop tinnitus, ringing in the ears. Cognitive symptoms, again, huge. Memory problems, difficulty concentrating, difficulty making decisions, difficulty finding words or sequencing information, things that most of us, unless there's people out there who have suffered a TBI, take for granted and it just happens. Many times, and I've met people who I know have had TBI, and I've talked to them about this, they can come across fairly normal. But when I've talked to them and asked them if they have any of these symptoms, they'll say yes. For example, I really have a hard time finding words. And I said, well, that's really interesting. I would have never noticed it. But as I talk to them, they are working so incredibly hard in their brain, figuring out workarounds so they come across as normal and no one notices. That is one of the reasons. And also I'll get to another one in the next group, but one of the reasons why this is often a hidden disability, an invisible disability, especially in this mild TBI, because there's no outward evidence that anything has happened. It's all going on inside of their head and they're struggling to function. The emotional symptoms, often they become easily agitated. They can have mood swings for no apparent reason that they can tell. Persistent anxiety, feelings of shame or guilt. This is another reason that I think this is often a hidden or invisible disability, because they're hiding what's going on. They don't feel normal. They don't want people to know. They're ashamed of it. And that makes it even harder for them to reach out for help. Often that people will describe feeling inept or worthless. And then lastly, there's the behavioral symptoms. Impulsive behavior. I want you to remember this one for a comment I make later on, why that's an issue. Verbal outbursts, physical outbursts. Some people with TBI get lost easily, and changes in sleep patterns are very frequent. Just a brief comment about chronic TBI symptoms. So in medicine, we have 2 basic categories of problems. Acute problems, something that's happening right now and then resolves in a time, and TBIs can be like that. You get a bump on the head, maybe you're feeling a little bit dizzy, don't feel well, a little bit of headache, but then over weeks, maybe a month, things resolve. And then chronic disease or chronic TBI symptoms, these are symptoms that maybe get a little bit better, but then they never completely go away. Now, mostly when I went out there and looked, there was this sense that for the most part, the majority of mild TBI, this resolves within 3 months. But I found this interesting quote from, it was actually a kind of report called a scoping review, looking at other literature out there about asking that question, is how common is chronic TBI after concussion or a mild traumatic brain injury? Let me just read this. Results indicate that in the results of their study, that in contrast to the prevailing view that most symptoms of concussion are resolved within 3 months post-injury, approximately half of individuals with a single mild TBI demonstrate long-term cognitive impairment. I'm going to talk about the numbers coming up. So just keep up, if this is true, if half of people with a mild TBI have ongoing chronic symptoms, let's look at what that might mean for numbers as we go along. But before we do that, I want to get back to Micah. This was Micah's, some of the symptoms he was having. He was having severe memory problems, blurred vision, very sensitive to light and noise. He had severe fatigue, persistent headache and neck pain, slowness in his thinking, his speaking, and his reading. He felt depressed, very poor sleep. He was easily distracted, and he had a loss of sense of smell and taste. So you can see he had a number of symptoms from each of those, for many of those categories I described. Okay, what's the scope of the problem? Looking at the CDC site, they had some statistics from 2014, 1 year in the United States. They counted, going through ER visit, hospitalization, and all the reports they collect, 2.87 million TBI-related ER visits, hospitalizations, and death. Fortunately, most of these, 2.5 million, were treated and then released from the emergency room. But going back to what I was talking about with the chronic TBI, if half of mild TBI sufferers have chronic symptoms, that's over 1 million people in 1 year having chronic symptoms. That just blows my mind. Over 800,000 of these were children, over 56,000 deaths. And in addition to that staggering 2.87 million number, many people with mild TBI never even report it. So it's clearly higher than this. How much higher? We don't know. Some more TBI facts, some for me very sobering. Men are approximately twice as likely as women to sustain a TBI. Young men, some reports I've seen 5 times more likely. This is something that I didn't know until I started looking into it. Many people don't know. Head injury doubles a person's risk of later mental health problems, even in people with no prior history of mental health issues. And here's where we get to really some, for me, shocking statistics. Having a head injury increases the risk of offending and being arrested by 50%. And if we go into the prisons, and people that have gone into the prisons and actually asked and studied this, 60%, 60% of adults in prisons and 30% of young offenders have a history of head injury. And that's contrasted to only 8.5% in the general population. This is often not identified. No one knows this until people went into the prisons and started asking people. So I want you to go back and just remember the symptom slide and that impulsive behavior and that emotional lability and mood swings. And can you see how that might result to a certain amount of crime? When they've studied it, they've also seen that it leads to a lot of recidivism. because when people are paroled, serve their time and paroled, they have to do certain things. They have to check in. And if their brain isn't functioning and they don't do well with keeping appointments and can't remember things and can't sequence and can't make decisions, I think you can see how this can keep people just churning through the justice system. Briefly just touching on the cost. Hard to estimate. I guess that's why we have economists. In 2000 in the US, in one site that I found, they estimated the direct medical cost and the indirect cost, lost productivity, totaled an estimated $60 billion. That's just in the United States. And this, of course, does not include the human costs of head injury, the negative effects for each person on their well-being and quality of life, and the disruption in their families. If you remember at the beginning, Micah had a young child and a wife, and this certainly his head injury impacted that whole family unit. Is there a solution? What is the solution? Well, let's start off looking at conventional medicine, where we have something very amazing. It's called rehabilitation. These people do amazing things. On one large hospital chain site, they were talking about, answering questions for potential patients about what does rehab look after head injury. And I'm again just going to read this quote. How long your rehab lasts and how much follow-up care you will need afterwards depends on how severe your brain damage is and how well you respond to therapy. Okay, makes sense. Some people may be able to return to the same level of ability they had before TBI, and others need lifetime care. And some long-term effects of TBI can show up years later. You may be at higher risk long-term for problems such as Parkinson's disease, Alzheimer's disease, and other forms of dementia. This especially has been coming to light in the last several years with the American football, and also as well as boxing, that we're seeing these diseases and starting to link that up with all of the repeated head injuries these people have. Also, rehabilitation may involve a number of different therapies: physical therapy, occupational therapy, psychiatric, psychological care across the board, which is very, very time consuming, a lot of man and woman hours, and often very expensive. The ISPS solution. Let me tell you a little bit about the TBI process. First of all, this is not treating the individual symptoms of TBI. So we don't have someone come in and they say, okay, I have memory problems. Okay, let's look at trauma. Let's see how we can address the memory problems, or headaches. Let's address that. It's possible that would, for each person, again, just like with the rehab, would be probably a slow and laborious process. But our absolutely brilliant ISPS research team found a very, very early key developmental event for the brain. What they found was trauma at this event leads to what we call decreased brain resilience in the present. Let me just tell you a little bit about how we think of resilience. And there is this concept of brain resilience in brain research. This is not necessarily the same thing, but this is how we're thinking of resilience. And this is one of Grant's little thought experiment that he loves to talk about. So if you imagine there's 10 people that you have lined up, and you take the same very heavy brick and drop it on their heads from the same distance. So basically you're giving the exact same blunt force trauma to each of these 10 people's heads. Now we can imagine that there's a range of problems that result. One problem might be to you because one guy with really good brain resilience gets very angry and punches you in the nose for dropping a brick on his head. At the other end of the continuum, maybe someone actually loses consciousness, maybe even goes into a coma if they have very poor brain resilience. So that somehow that intuitively makes sense that there's going to be a different reaction to the same force. And the question is why? And our understanding is that it has to do with the resilience of their physical brain to be able to withstand that type of force. Some people have more and some people have less. And that was traced back by the team to this very key developmental event. And what they found was regressing a person back to this event, healing all the trauma using very simple trauma healing tools, that healing the trauma at that moment restored brain resilience. And lo and behold, we'll have to ask Grant to see, I don't think they were expecting this, but lo and behold, what happened was in the present, the client's symptoms either resolved or greatly improved. So something has changed in the past that we believe is increasing the brain's resilience, that, if you will, echoes or ripples forward in time, and in their present, their symptoms go away. It's like they move from that 10th person who just had this huge impact to the person who has no symptoms at all and is punching you in the nose. The other comments I want to make about the TBI process, again, I said it uses simple trauma healing techniques, which are guided by someone trained in this process, and can be done by video conferencing, just like we're using here. All right, back to Micah. Micah went through this process. He was treated, oh gosh, I want to say 3 or 4 years ago. He worked with his therapist. So his symptom list, his memory improved. He didn't have any change in his blurred vision, but he did have decreased sensitivity to light and noise. His fatigue was greatly improved. His headache and neck pain nearly gone. His speed, his ability to think, speak, and read were now much more normal. His depression improved. His sleep was nearly normal, became much less distractible. Unfortunately, his sense of smell and taste did not return. So it wasn't 100% all at once, but his symptoms dramatically changed. And here's what Mike has said. There have been dramatic changes in my life. I started to get inspired. I'm able to remember better. I process emotions better. That helped my relationship with my wife. There's that relationship impact. Through the process, things started to change. I created a business and did the paperwork. I would have been unable to think about doing that before this process. I began to learn German. Oh my gosh. I could not have done that before this process. My brain could not process it. I'm excited about my life again. People that we do this process with and their symptoms resolve or greatly improve tell us these things over and over. This is what lights me up. This is why I'm passionate about the process, because of the ability to impact Micah's life and get him back engaged and functional and contributing to society. Let's talk about some challenges moving forward. Well, let me talk about them. You don't get to talk apparently right now. I want to tell you a little about the history of the TBI process. Back when this process was developed, Grant can correct me if I'm wrong afterwards, I believe it was about 12 years ago. In any event, the research team did not set out to study TBI or to develop this process. That was not what they were doing. They were actually working on finding a treatment for autism. It's been a core aspiration of the research team. And they were working with kids with autism. And what they were digging around back in the subcellular psychobiology and those prenatal events, and they developed this process or found this event, and they tried it on some kids, and a couple of kids, their symptoms went away. Their symptoms of autism went away. And they went, oh, okay, we think we found something. They then tried it on more children, and it didn't do anything. Wondering, why is this? Why did it work on these couple and not the others? What they actually figured out was that the kids that it worked with didn't have autism at all. They actually had undiagnosed chronic traumatic brain injury, and that's why it worked. So the research team did a little bit more work, checked it out in people with diagnosed chronic traumatic brain injury, and saw, yeah, this works pretty darn good. This is cool, but we're not working on TBI. We'll just sort of put that aside and come back to it, and went on studying autism. That is actually why I returned to the Institute and am now the medical director, is because when I was chatting with Grant about this, he told me that they had this process for TBI that worked pretty darn good, and no one was really using it. And I went, what? That's not right. Do you know how big of a problem TBI is? So that's why I am here. Now, getting back to Micah, his therapist used an earlier version of the process. And as you've heard, Kirsten talked about this, they talked about this last time, these processes, as they go through research and they get tested on more and more people, they go through iterations and different versions. So he had one of the earlier versions and worked pretty darn good. But as we've continued to test more people, we found that some people were not able to finish the process, or seemed to finish it, but had minimal changes in symptoms. Sometimes symptoms would go away and then it would reverse. And again, back to research, looking at this, more discoveries. And over the last year, there have been some big breakthroughs in research on improving this process. And actually the latest version is starting to be tested right now. So I have great hope that with these newer versions that my thought is, and Grant's as well, is that they're going to be even more robust. So very excited about what's coming down the pipeline here. Let's talk about a few other things. What about severe TBI? What about people who have a severe TBI, so severe that they actually never regain consciousness, that are in what is sometimes termed a vegetative state, although that's not really politically correct in medical circles anymore, although it's still commonly used, or what is called a minimally consciousness state. So these people need 24/7 care. They can't eat, feed themselves, they can't interact. In minimally conscious, they have a little bit ability to interact, but they're not speaking and engaging. We have actually have worked and are working with 2 patients in this category. The first gentleman he's probably 25 now, but he had a severe motor vehicle accident 4 years before I met him, and met his family and him, and basically lies in a nursing home. For 4 years, he's been lying in a nursing home, diagnosed with a vegetative state. He's tube fed. All of his care has to be done for him. He doesn't interact. He didn't follow with eyes. And we never tried it on this kind of client. Didn't know if we could. So the research team worked with him and his sister and father. I must say his family is extraordinarily devoted to him, are visiting him all the time. So they were happy to do anything to try to help. We did the initial process with him, which, no, he didn't suddenly wake up. Although after we finished the process, his sister, who again was much more in tune with him, said, I can tell a difference. There's something different about how he was interacting, or how he looked to her. It was not obvious to me at all. We then continued to do more research and looked for other things that may be going on that differentiates this class of patients with that never wake up. They don't know. It's not that they just have chronic TBI symptoms, but they never regain consciousness, and learned a lot of stuff and did more work with him. I can't remember exactly how many sessions we did with him. I'm thinking about 4 or 5. And he now, again, was not clinically tested by a neurologist. I tried to push for that, but it hasn't happened as far as I know. But he became what I would call minimally consciousness. He started following people with his eyes. He started to smile. I got reports that he would laugh at times. His sister says that she thinks he's trying to say words, noises will come out. He was definitely differently engaged. And his mom said, "Oh, I can see my son in there now." Again, I just warms my heart. The other woman also was already diagnosed as minimally conscious, able to interact, and her mother could understand a little bit of what she was trying to communicate, although she is nonverbal. We did the process with her, learned a whole lot, but she did not wake up either. They are still on our being willing to work with us, and I am hopeful about our next iteration of the process to try it with them and see if we can continue to get them even more improvement in symptoms. So that's the severe TBI story. What about other conditions, other acquired brain injuries? Stroke certainly affects the brain. I don't know if this would help. We haven't tested it in a stroke victim. What about infections? Brain infection is called encephalitis. Grant, back when he was testing this initially, if I'm remembering correctly, worked with one client who had some type of encephalitis and giving him symptoms. And it didn't work. It didn't change his symptoms at all. That's the only case I know of. Otherwise, we haven't tested it in brain infections, meningitis, encephalitis. Cerebral palsy is another type of brain injury that happens either pre-birth or at birth, and could certainly, in many instances, be categorized as a brain injury. Again, we have not tested in those cases. Not that I'm not willing to, we just haven't had that opportunity yet. Other challenges. Okay, well, the big challenge that this is way outside the current medical paradigm. For those of you who were here yesterday, Kirsten talked about the 13th annual brain injury conference that she and I went to in Toronto a year ago. There were certainly people that were receptive, interested, as we had our poster there and people came by. I talked to all kinds of people and some of them were very intrigued. What we were looking for was research collaborators. And in general, it was very interesting. A lot of the doctors and researchers I would approach and try to describe this or tell them what was going on, I could see them, they were very polite. They were all very, very polite. None of them told me I was crazy to my face, but I could see them, it's like that paradigm dissonance just happening in their brains. It's like, what the hell is she talking about? And one of the things I would describe in this process, we actually use a very specific piece of music, some music that helps regress people and get them back to the right state. So I was describing this to one researcher and he clicked on that. He goes, okay, I know, you need to talk to the music therapist. That's sort of the category I put in. This is just sort of something a little weird. I don't know how music therapy works. We think it might help a little, but you go talk to the music therapist. In any event, it was interesting. Part of that may well be how I'm describing it, but for me, it was more this problem of the paradigm dissonance that just blew up big time. The other problems that we have, the other challenges, is right now we research consciousness. We don't have a lab. We don't have a huge budget. We don't have any budget. So we haven't done MRI scans or CT scans before and after to see, is there anything that we can see changing? We don't have any published case studies, no clinical trials, of course. And all of those things are basically what gives someone street cred with the medical community. So it's proved challenging. A bright spot, we have a recent affiliation with the Cambridge Brain Sciences, which has a very scientifically validated cognitive assessment tool that can be done online. So we're now affiliated with them, have talked to them, and are beginning to use that. It's just looking at the cognitive symptoms. So this is a cognitive assessment. It's not looking at the other symptoms, but that's very, very common. So we're going to start doing before and after with that. And because they've already scientifically validated it, that will give us at least some information that we're interested in obtaining. In conclusion, for me, the TBI process has the potential to help thousands and thousands of people who are suffering, often in silence, with no hope of recovery or change, suffering with these often devastating chronic symptoms of traumatic brain injury. Our latest research findings are very promising for an even more robust process. And we are actively looking for research collaborators. We know we need to talk with the community out there, to collaborate with them, to start to hook up some of these, what we're finding with those objective results. So we're actively looking for that. If you know of anybody who might be interested in collaborating with us, please get in touch. All right. I did pretty good. I had an extra 15 minutes that Kirsten and Grant gifted me, and I didn't use it all. I am totally willing to entertain any questions or thoughts.
Thanks, Mary.
Yeah.
So from Sergio Lil, what is the link between TBI and mental illness when psychobiology work classifies mental illness from other trauma? Does it work as a trigger from an earlier survival trauma?
I don't know. The link with mental illness is something that's been seen and reported in the literature. Not super well known, but it's certainly reported in the literature. And I'm not sure they know what the link is, except that, you know, our emotional mental health is connected with how our brain is functioning, and when that's functioning less well, that seems to lead to these problems. How it links in with our model is a good question. We haven't looked at that. Hold on, just let me think here a second. Certainly, when you have damage and trauma, it can trigger, I think you mentioned that, trigger other traumas, which may then lead to various mental illnesses. I don't know, Shane, do you want to weigh in on that?
No, I'm focusing on working out what the next question is I'm going to ask you.
Okay, give me the next question. So I don't know if hopefully, basically we don't know.
Yep. Okay, from Dr. Douglas Schneider, what is the very early developmental trauma you mentioned early in the talk?
Well, it's back at someplace we call the origin, basically the origin of the matter that eventually becomes the brain.
Okay. Question from Edward Soroto. Did you try to do MRI or CT? They don't show any difference before and after, or is it not so easy to see the difference?
Well, two problems. The first one is that in mild traumatic brain injury, it's generally thought there are no CT or MRI findings. That's the first thing. Now, as it turns out, and as something they were talking about at the brain injury conference that Kirsten and I went to, as they get more sophisticated in how they're doing those tests and different ways of doing MRI, they're thinking there may be changes they can pick up, but these certainly aren't mainstream. So the first problem is that in the vast majority of TBIs, which are mild, there are no changes to start with. However, some of the people we've worked with have had changes because they had moderate TBIs or even severe TBIs in those two cases with changes. But we don't have any funding for doing that. That's one of the reasons we want to collaborate with an organization that works with TBI and has the capacity to do that. And because, you know, people go, well, what happens inside the brain with when their symptoms get better? I don't know. Does it rebuild? Does the brain just, is the damage still there, but it's going around it? We can speculate on that, but we have no physical evidence for that.
Okay, and probably a follow-up to that from Dr. Douglas Schneider. Would quantitative EEG be a tool to work with in looking for changes in brain function?
Possibly. And possibly, I don't know enough about it, but it's certainly a lot less expensive and more accessible than CTs and MRI scans. I don't know if our questioner has any ability or resources in that, but hey, I'm all ears for anything. But we haven't looked at it.
Okay. Keith Brown has asked, have you tried third generation treatment on Micah?
No. He moved away from Hawaii and is, I think, living in Europe last I heard. And I was in contact with him through the therapist that worked with him, who lives in England. And then she lost contact with him. So hopefully he's doing well. Just a funny little story about Micah. The therapist had worked with him, and she had over 3 months. His treatment took a long time. He had a lot of trauma, and because of his problem processing it, he was a little bit slower at doing it. And she knew he had gotten better, and when I started working with her, we were talking about gathering some information and doing some interviews. So she contacted Micah to see if he would do an interview. Now, she hadn't seen him for, I think it was 3 or 4 months after his treatment had finished. And so we got on it and did this interview. There was the 3 of us. I was the main interviewer. She was just sort of in the background. And I'm starting this interview and asking him all this stuff. And here's this brilliant guy. He's just rattling off all this stuff and telling me about stuff he's done before, very engaging, and on and on and on. And I'm like, okay, kind of cool. And the therapist, Karen, is sitting there in the background going, she had never seen this guy before. He was totally different than her experience of him going through therapy. He had changed so dramatically. She was just totally blown away at the transformation in him. Did I answer the question, Shane?
Yep.
Okay.
Okay, so Amy Zook, firstly, is saying awesome that we're looking for collaborators. Maybe the Dr. Amen Clinic would collaborate. I'm sure that's been on your potential list.
Yes, I'm looking for an in. If someone, if someone knows someone who knows someone in the Amen Clinic, I'm up for anything talking. But my experience has been, if I'm just off the street, and just sort of, it's kind of like, what are you talking about? It's just, I get put in a box of kind of crazy doctor lady. I am looking at, we do have a medical school here in Yakima, and I have had some conversations with them, and we'll continue to pursue that. They don't have a huge research department, but I'll continue to pursue that. But any other leads anyone has, all ears.
Absolutely. She also had a question which is similar to one you got before. We might need to explain why we're not going into the details. What developmental stage is responsible for the lack of brain resiliency in some?
Well, as far as we know, at this very specific developmental event, at the origin of the mind is what's responsible for brain resilience.
Yeah. So I guess for the audience, just letting them know, we're deliberately being a little bit vague around that, because this is not the kind of stuff you want to experiment with. You need to know exactly what's happening in this area. You need to be well trained to be able to do this. So as many of the presenters have said throughout the research symposium, don't go experimenting with this stuff. Okay. I've got another question here. Are there any other brain diseases or disorders that could be helped through using the same process to increase brain resilience?
Well, again, just reiterating what I said at the end, possibly stroke. Haven't had a case, don't know. Possibly cerebral palsy, which is real exciting. Haven't had a case, don't know. Of interest, though, again, a little side note, I work with an organization that works with people with disabilities. And several years ago, they did a fundraiser, and they had a nationally known comedian, and I'm totally blanking on his name. I didn't know I was going to talk about this. A comedian who has cerebral palsy. And it's basically he talks about that in his comedy. It's all about his disability, and he was hilarious. So he did a fundraiser here, and I talked to him backstage, and I said, theoretically, if there was a treatment that would treat your cerebral palsy so it was gone, would you do it? And he thought about it, and he said no. He said, I've made my fame. He was quite successful at this. Having cerebral palsy, I wouldn't want it to go away. So I thought that was very interesting. Did I answer the question?
Yes, you did. Yes, you did. No, I was just looking.
I answered before I went off on my tangent.
Yeah. So I got a question from Gary Palmer. Have you explored healing other organs at origin, such as lungs for asthma?
Not specifically lungs. It's definitely on the list. We're very interested in origin. So as you're cluing in, if there's an origin for the brain, there's probably an origin for other organs. Yes, we have had the exact same thought on the list, on the to-do list. Don't know where it is on Grant's list, but right now we're focused on the brain. Or I'm focused on the brain.
So I think that's it for TBI questions. So let me.
Thank you for watching. For more information, please visit www.pigstates.com and subscribe to our YouTube channel.